So, good evening all. Welcome to Smart Root Academy. Today we are going to discuss about a topic in cardiovascular system that is very, very important. You can expect so many MCQs from the theoretical part of this topic. Okay, so let's move on to the topic that is valvular heart diseases. So if there is any disruptions in between, you can rejoin with the same link. Okay, so let's move on to the condition. So before the condition, we will discuss about some basic things. First thing, we are studying about valvular heart diseases. So obviously, we should have a basic idea about the anatomy of valves. Okay, so in this picture, you can see the four valves. Okay, so and thus the first valve is the tricuspid valve. This valve, tricuspid valve. So this tricuspid valve is between right atrium and right ventricle. Okay, tricuspid valve is between right atrium and right ventricle. So this is having three cusps. You can see this having three cusps or leaflets. So it is known as tricuspid, not just the tricuspid valve. Pulmonary valve and aortic valve are having three leaflets or three cusps. Only mitral valve is having two leaflets. So that's why it is known as bicuspid valve. Okay, so then the next valve is which one? Pulmonary valve. Pulmonary valve is between right ventricle and the pulmonary artery, which carry the deoxygenated blood. We discussed it yesterday also. Then this is the left atrium. So between the left atrium and the left ventricle, there is mitral valve or the bicuspid valve. Okay, and between the left ventricle and the aorta, there is aortic valve. Okay, so this pulmonary valve, tricuspid valve and aortic valve are having three cusps, and only mitral valve is having two cusps. So that's why it is known as bicuspid valve. And you should also know which layer of the heart is covering this valves and chambers. You know that the heart is having different layers, so that we will discuss it in another class. So which layer is covering this valves and chambers? Which layer? That is endocardium. The endocardium lines the valves and chambers of the heart. Okay, so next we are moving on to the detailed anatomy of the valves. So here you can see, you should have a basic idea how these valves are located, so that will help you in understanding the treatment modalities more easily. So here you can see the valve. This is the picture of mitral valve. Okay, so here you can see the valve. So this is the valvular structure. So around this valve, there is a ring-like structure, no? One ring. So this ring-like structure is known as annulus. Okay, the ring-like structure which support the valve to be in place, that is known as annulus. Okay, then the main thing in here is this structure, this string-like structure from the valves. Some ring-like structure you can see on both sides. The string-like structure is known as chordae tendineae. This will attach the valve to the papillary muscles. Okay, so this helps in the attachment of the valves. This chordae tendineae are string-like tendinous structures which helps the attachment of the valves to the papillary muscles. Okay, so this is the basic anatomy. You should have an idea about it. So next we are moving on to the heart sounds. Okay, so you all know that the normal heart sounds are, first sound is lub and dub. Okay, so how these heart sounds are occurring? So these two are the lub and dub are the normal heart sounds. The first heart sound is known as sound 1 or S1, and second heart sound S2. So other than this two heart sound also, in some condition, some other sounds also we can hear. So let's discuss about that. So S1 produced by closure of mitral and tricuspid valves. That means by closure of the atrioventricular valves, the valves between both the atria and ventricles, both the valves, mitral and tricuspid valves, when these two close, then what will happen? The first heart sound S1 will be produced. S2 produced by closure of aortic and pulmonary valves. So if this valves close, that means if the blood is ejected out from the ventricles and the valves between both the ventricles will close, that is the aortic and pulmonary valves, so that the second heart sound will be produced, that is the S2. So these two are the normal heart sounds. Okay, then some extra heart sounds also we can hear in some conditions, that is S3. S3 is due to passive filling of ventricles in diastole. Diastole means relaxation of the heart. So during relaxation of the heart, due to passive filling, the ventricles should be adequately filled now in diastole. But in what will happen, some condition there is passive filling of the ventricles only. So in that case, S3 will be there. Okay. S3 will be there. So this S3 we can mostly observe in mitral regurgitation. Why? Because during diastole, the ventricles are adequately relaxed, but the mitral valve is insufficient. Regurgitation is also known as insufficiency. So the mitral valve is insufficient, so that the blood will go back to the atria. So that passive filling of the ventricles only will be occurring. So in MR or mitral regurgitation, loud S3 we can hear. Then S4. S4 due to rapid emptying of blood from atrium to ventricle during diastole. So diastole, at the time of diastole, there will be rapid emptying of the blood from atria to ventricle. So due to that, what will be happening? The S4 we can hear. So S1 and S2 are, these two, S1 and S2 are normal heart sounds, and this S3 and S4 are extra heart sounds. Okay, so this is about the heart sounds. Next important thing while studying the valvular disorders are the heart murmurs. So what are these murmur? What is this murmur? How it is occurring? Let's see. Heart murmurs are produced due to turbulent blood flow through a constricted or irregular orifice due to increased flow. So there is increased flow, or there is so much obstruction in between, or the blood is rushing through the valves, so that what will be there? Some rough sound will be there, or some swishing sound will be there. So some rough sound. So turbulent means some rough sound we can hear. So this turbulent blood flow, that means in force the blood flow is happening. So due to that, it can happen in a constricted or irregular orifice. Orifice means opening. So if the opening through the valve is constricted or narrow, or it is irregular, then what will happen? There will be turbulent or rough blood flow through that, and that will make this swishing sounds known as heart murmurs. So the heart murmurs can be divided into systolic murmur and diastolic murmur. Systolic murmur begins during or after the S1 and ends before or during the S2. So at the time of S1 or after the S1, the systolic murmur will be occurring, and it will end before the second heart sound. Diastolic murmur begins during or after S2 and end before S1. So during the second heart sound or after the second heart sound, diastolic murmur will be occurring, and before S1 it will end. Okay, so this is about the heart murmurs. So Levin and Freeman gave a grading for the murmurs. So according to their gradings, we can see while we are assessing the patient, according to this grading, we can see how the patient, what is the grading of the patient, what is the level of injury for the patient. Grade 1, very soft, heard in optimal conditions. Okay, so very soft sound, so the patient's condition won't be so much bad. In grade 2, faint murmur but clearly audible. Okay, so murmur may be faint, but it is clearly audible with auscultation. Okay, so that is grade 2. In this, the abnormality is somewhat bigger. Then grade 3, moderately loud murmur but no thrill. Thrill is not present. That means during palpation and all that rough sound we can't palpate, but murmur is loud. Murmur means we will put a stethoscope to that means we will auscultate, so that time we can hear a moderately loud murmur, but thrill won't be there. Then grade 4. Grade 4 means loud murmur with thrill. Thrill means while palpation also we can feel that murmur. Okay, so that is grade 4. This is a severe condition. And in grade 5, louder with thrill and can be heard away from the involved site. So if you are placing the stethoscope not on the involved site also, that means anywhere in the chest, if you are placing our stent away from the heart also, we can feel or hear that murmur. So this is a severe condition. And the grade 6, the most severe conditions only we will say that the patient is having grade 6 murmur. So what is that? Murmur with thrill heard even if stent is lifted off from the chest wall. So even if we lifted the stent from the chest wall also, we can hear the murmur. That means that much turbulent blood flow is happening. So this is about the grading of grading given by Levin and Freeman for murmurs. Okay. Next, we are moving on to the valvular disorders. So whatever we discussed, you should keep it in your mind so that the upcoming theory will be easy. So valvular disorders, mainly the main valvular disorders are termed as stenosis and regurgitation. Regurgitation is also known as insufficiency. Okay, so we are having 4 valves. So to any valve, this stenosis or regurgitation can happen. So this stenosis is mostly known as, or we can remember it like opening disorder, opening problem. The valves are not opening properly. In regurgitation, it is a closing problem. Okay, remember like this so that it will be more easy. So stenosis is the opening problem. That means the valves are not opening properly. And in regurgitation, it is a closing problem. The valves are not closing properly. So I will make it more clear for you. So here I will draw. You consider this as a valve or like a dose I am drawing it. It is not the original structure. I am just for your understanding, like a door I am illustrating. So in this, the valve so the valves should be closed like this. Okay, so this is consider this as a normal closed valve. Okay, And when the valves are open, it should open like very widely so that the blood can flow adequately through this area. So this is normal open. And in stenosis, what will happen? The valves won't open well. So like this, the valves will be. That means the valves are not well opened here. Okay, so a very narrow opening is there. So the blood will force through this narrow opening. So some will go, some blood won't go. So a turbulent thing will be happening here. So this condition, that means the valves are not opening properly. That is known as stenosis. Okay. So this is about stenosis. And in regurgitation, what is happening? Here, I will again show the normal opening. Normal opening is like the valve should be widely open. And in normal closed, what will be there? The valve should be tightly closed so that even if the blood wants to come back also, it cannot get in. It have to go back because the valves are closed. So this is normal closed. Okay. So in regurgitation, what is happening? It is a closing problem, no? So something like this will be happening. That means the valve should be tightly closed, and sometimes the one side may be floppy or something like this can happen. So what will happen? The blood somewhat gone out, and some can get in like this also because a small opening is there. So this condition is known as regurgitation due to abnormal closing of the valves. The valves are not closing properly so that the blood is backing up to the atria. So this condition is known as regurgitation. Not only atria, the above structure, wherever the blood is backing up, that condition is known as regurgitation. So basically, as I said, stenosis is a opening problem and regurgitation is a closing problem. I think you guys are clear with it. If you are having any doubt, you can ask. Then I'm moving on to different valvular disorders. So mainly, almost all the valves are having the stenosis and regurgitation only. So main conditions we are seeing as valvular disorders are affecting the mitral and the aortic. So we will be discussing both of them only. So then we will be discussing about the treatment modalities and the warfarin therapy, everything. Okay, so let's start. What is mitral stenosis? I already said that mitral stenosis means an opening problem. So here you can see normally mitral valve orifice. That means if the mitral valve opens, it should be 4 to 6 centimeters square. Not it. Normally the mitral valve should open about 4 to 6 centimeters square. But in mitral stenosis, that means the mitral valve is not opening properly. If it is a mild condition, there will be 1.5 to 2 centimeters square opening will be there. If it is a moderate condition, 1 to 1.5 centimeters square only opening will be there. And if it is a critical or severe condition, only less than 1 centimeter square opening will be only be there. So this is according to the severity. The mitral stenosis can be divided to mild, moderate and critical. In mild, 1.5 to 2 centimeters square opening will be there. In moderate, 1 to 1.5 centimeters square opening will be there. And in critical, only less than 1 centimeter square opening will be there. So see how difficult for the blood to pass through this stenosed valve. Okay, so this is about mitral stenosis. So what is the pathophysiology? If the blood is not going adequately, or if the valve is not opening properly if the mitral valve is not opening properly, what can happen? Let's see. Obstruction to left ventricular inflow. The blood is not properly going to the left ventricle. So what will happen? The blood volume inside the left atrium will be increased. So that will cause the blood volume is increased in the left atria. Why? Because the blood is not adequately going to the left ventricle. So there will be increased pressure in the left atrium. Increased pressure, that will lead to increased pressure in pulmonary veins. So if there is increased pressure in the left atrium, what will happen? The blood flows back to the pulmonary veins. You're getting my point, no? If increased pressure is there in left atrium, the blood will go back to the pulmonary veins. So that what will be there? Even if the blood is not going back also, the pressure will be increased inside the pulmonary veins also due to the congestion. So due to increased pressure in the pulmonary veins, what all things can happen? Yeah, your answer is correct. You guys are following very nicely. Pulmonary artery hypertension. And if pulmonary artery hypertension is there, what will happen? Right ventricular failure. Due to pulmonary artery hypertension, right ventricular failure can happen. This we discussed in detail in the heart failure class. Then what will happen? Finally, it will lead to tricuspid regurgitation also due to the pressure. So it started from the mitral valve. So obstruction to the left ventricular inflow, increased pressure in the left atria, pressure in the pulmonary veins, then pulmonary artery hypertension happened, then right ventricular failure. Due to right ventricular failure, tricuspid regurgitation will also follow. Then if the pulmonary artery hypertension doesn't happen, then what will be there? Pulmonary edema. Why? Because the blood is backing up. So that will cause congestion inside the lungs, causing pulmonary edema develops if pH does not develop. Okay, so this is about the pathophysiology of MS. So in this pulmonary artery hypertension, due to that right ventricular failure and tricuspid regurgitation happen. Otherwise, it will cause pulmonary edema. Okay, so this is about the pathophysiology. Next, the clinical manifestation. Okay, so in this valvular disorders, most of the questions are from the signs and symptoms. Okay, so some specific signs are there for some valvular disorders. So let's see that. So symptoms means whatever the patient is experiencing, and signs means whatever we can observe. So symptoms are, first one is dyspnea, this is a breathing difficulty, orthopnea according to position change, what is the patient is feeling some breathing difficulties, palpitation, the patient can feel his heart rate or it is beating very hardly, then fatigue, yeah, tiredness, then hemoptysis. What is this? Hemoptysis is blood in sputum. Then recurrent bronchitis they will be experiencing. These are the major symptoms. In signs, first one is mitral phases. What is this mitral phases? In mitral stenosis, one specific sign we can observe in the face. That is known as flushing of cheeks. Flushing of cheeks. This we can observe in mitral stenosis. This is a repeated question. You should note this. In mitral stenosis, there will be flushing of cheeks. That is known as mitral phases. Then a small volume pulse we can observe or we can auscultate. Then left parasternal heave. Heave means a lift. Okay. So in left side, in the parasternal area, we can observe a lift. Okay. So that is, so that can be, it cannot be visible. In palpation, we will feel a lift in the left parasternal area. So that is this. Then tapping apex. In the apex area, tapping we can find. Then opening snap. At the time of opening, a snapping sound. Then MDR murmur. MDR murmur means mid-diastolic murmur. Mid-diastolic murmur. So we already discussed about what is systolic and diastolic murmur. So mid-diastolic murmur we can observe in mitral stenosis. Then ejection systolic murmur if there is PAH in pulmonic area. So in pulmonary, you all know that wherever the auscultation will be done. The auscultation of in cardiovascular assessment, the auscultation will be done in aortic area, in the second intercostal space, then the same second intercostal space in the left side, the pulmonic area, then the mitral area, then the tricuspid area. The cardiovascular assessment will be done. That means if during cardiovascular assessment, the auscultation will be done in aortic, pulmonic, mitral, and tricuspid area. Okay, so during this time, the pulmonic area, that means in the second intercostal space, in the left side, we will be hearing this ejection systolic murmur. Then diastolic trill at apex. Trill we can observe in the apex. Then the complications. So these are the major signs. Then the complications due to back pressure, example pulmonary. So back pressure, what all complications can occur? We already discussed in the pathophysiology, pulmonary edema, pulmonary artery hypertension, right ventricular failure, and tricuspid regurgitation. Then arrhythmias we can observe. Then infections, then embolism, pressure effects. So due to pressure, due to pressure, some problems can happen. Then hemoptysis, blood in the sputum will be there. Then what all investigations we have to do for identifying this valvular disorders? Chest X-ray. In chest X-ray, what will be there? Left atrial enlargement. Because due to continuous pressure, there will be left atrial enlargement. So that is visible in chest X-ray. Calcification of mitral valve. So if the mitral valve, due to mechanical stress, it can be calcified or fibrosis can be happen. So that's why the valve can't open. So that may be there. Straightening of the left heart border. So everything we can observe in the chest X-ray. Then ECG, in ECG also left atrial enlargement, RPH, AF, everything we can observe, atrial fibrillation. Then in echo, the total structure and the blood supply or the blood moving through the heart, everything can be observed. So this is also a very good investigation. Then cardiac catheterization, if you are doing also, we can find out this valvular issues. So the treatment is rest, salt-free diet. If the condition is not worse, we will go for this these things like rest, salt-free diet, sodium restriction, then diuretics. So this treatment is mainly like heart failure treatment. Diuretics, digitalis, embolism. In case of embolism, we will give anticoagulants. Then rheumatic fever and infective endocarditis prophylaxis. Why? Because mostly these valvular disorders are happening due to these two conditions. What are these conditions? Rheumatic fever and infective endocarditis. So this rheumatic fever will cause rheumatic heart disease, that is causing mostly valvular diseases. Okay, so prophylaxis for this rheumatic fever and infective endocarditis is one of the treatment. If you are treating these conditions, the valvular problem, the treating the valvular problem will be more easy, or we can even prevent the valvular disorders. So about this rheumatic fever and infective endocarditis, we will be discussing in the next class. Okay, so this is about if the condition is not worse, we will go for these things. If the condition is worse, the valve is not at all functioning, we should go for surgery. First one is commissurotomy. This is separation of fused valves. So if the valves are fused, that's why it can't open, means we will be doing commissurotomy. Then balloon mitral valvuloplasty, the valves will be repaired. Then mitral valve replacement we will be doing. So this is a very big surgery and an important surgery. So after this valve replacement, the patient should be in continuous warfarin therapy throughout their life. So this we will be discussing in detail at the end. So we are moving on to next, that is mitral regurgitation. So as I already said, what is regurgitation? It is a closing problem. The mitral valve is not closing properly, so that the blood is backing to the left atrium. So this is mitral regurgitation. I think you guys are clear. The mitral regurgitation, the valve is not closing properly, so that the blood is going back to the left atrium. Causes. Chronic causes, acute causes are there. Chronic causes, rheumatic heart disease, congenital mitral regurgitation, cardiomyopathy, connective tissue disorders like SLE. Then aortic valve disease, it's there due to the pressure. The mitral valve also can be damaged. Then hypertension is one disease that can cause this mitral regurgitation. Then ischemic heart diseases. Then inflammation of the myocardium, that is the myocarditis. Then acute conditions, I already said that this rheumatic heart disease and infective endocarditis are main conditions for all the valvular disorders, mainly the aortic and the mitral. Then MI, if it is happening, that can also cause trauma. Ruptured caudate tendinae, how it will be happening? I already said in the anatomy part that the caudate tendinae are string-like structures which hold the valve to the, which hold the valve in place, which connect the valve to the papillary muscles. Okay, so if the caudate tendinae is ruptured, what will happen? Obviously, the valve won't function or won't close properly. That will finally lead to regurgitation. So that is about ruptured caudate tendinae. Then myocardial abscess. Myocardial abscess. Then prosthetic valve endocarditis. Okay, so if even after valve replacement also, the infective endocarditis can occur and it can again lead to mitral insufficiency. I'm again saying regurgitation is also known as insufficiency. Then we can see the pathophysiology of mitral regurgitation. First, what will be there? Left ventricular dilatation will be there. Okay, so due to continuous pressure, the left ventricle starts dilating. Because how this is happening? The regurgitation is happening means the blood is backing to the left atria. So that increased blood volume in the left atria will be there. So in next stroke, what will be there? So much amount of blood is coming to the left ventricle. So that left ventricle also will be undergoing some pressure. From that also some blood is again going back. So this process is continuing means left ventricle also gets some pressure and left ventricle undergo dilatation. Then increased O2 demand of myocardium. So if there is increased cardiac, if there is increased cardiac workload, what will be there? The myocardium need increased O2 for energy. Then finally it will leads to left ventricular failure, increased left ventricular filling pressure. The filling pressure, when the blood is filling inside the left ventricle, the pressure will be increased. Then increased left atrial pressure, that leads to the pathophysiology as before. It will cause pulmonary venous pressure and finally pulmonary artery hypertension. So finally, what will happen? Like before, it can cause right ventricular failure also. It can rotate like that. So in this way, the pathophysiology will be. So in clinical manifestation, the symptoms are fatigue, palpitation, left ventricular and right ventricular failure symptoms. We already discussed heart failure symptoms. So these symptoms we can observe. In left ventricular failure, what was there? Respiratory symptoms like dyspnea, orthopnea, paroxysmal nocturnal dyspnea. These conditions in left ventricular failure. And in right ventricular failure, there are systemic symptoms like pedal edema, ascites, hepatomegaly, splenomegaly. Those symptoms we can observe in right ventricular failure. Signs: wide pulse pressure. What is pulse pressure? Pulse pressure is the difference between systolic and diastolic BP. Difference between systolic and diastolic BP is known as pulse pressure. So in mitral regurgitation, there will be a wide pulse pressure. Okay, then as I already said, there will be loud S3, the third heart sound we can observe, and that will be very loud. And what this S3 is indicating? S3 means there will be only partial filling of the ventricles. Okay, then PSM murmur means pan-systolic murmur. Then parasternal heave also we will be getting with this mitral regurgitation. So this is about the clinical manifestations. Then the management. In management, vasodilators, example AZ inhibitors we will be giving. See, these are all supportive therapy only. Then if atrial fibrillation present, digoxin or anticoagulation we will give. Then rheumatic fever and infective endocarditis prophylaxis. Then CCF treatment, congestive cardiac failure treatment. If present, we will give the treatment for that. Then acute symptomatic mitral regurgitation. If the mitral regurgitation is symptomatic, then we will go for mitral valve replacement. So anyway, the final treatment will be the valve replacement only. So that's about the mitral valve regurgitation. Next, we are going to aortic valve. What is aortic stenosis and aortic regurgitation? Let's see. So, aortic stenosis, normally aortic valve opens about 3.4 centimeters square. Okay, normally it will open about 3.4 centimeters square, and in stenosis, proper opening won't be happening. That means less than 1 centimeter square only the aorta will open. So that is the stenosis. So you can see, what is the difference between these two. So that's how the turbulent blood flow will be happening in stenosis, and the murmurs will be produced. So what are the causes? So one more thing I want to say in mitral stenosis, that is in mitral stenosis, we already see this mitral stenosis is one major reason for increased mortality at the time of labor or childbirth. Mitral stenosis is one of the major reason for increased death. Or it doesn't mean that all the people who are having mitral stenosis will die, not like that, but increased chance for death is increased in mitral stenosis. So now we are studying about aortic stenosis. So let's see the causes. Mechanical stress over time, that means calcification or fibrosis will happen according to time. Then bicuspid valves. Okay, so what we are studying? We are studying about AR or aortic regurgitation. Sorry, aortic. I'm sorry, that is aortic stenosis we are studying. So in aorta, how many cusps are there or how many leaflets are there? 3 leaflets are normally there should be 3 leaflets or 3 cusps for the aortic valve. But in some conditions or congenitally or from birth itself, the person may be having only 2 cusps for aorta. So I already said in the anatomical part that 3 of the valves are having 3 cusps. Tricuspid, aorta, and pulmonary are having 3 cusps. Only mitral will be having 2 cusps. So in genetically, some people are having only 2 cusps for the aorta. So in this condition also, AS can happen. How? Because the pressure which should be distributed between 3 cusps is distributed only between 2 cusps here. Okay. So due to this, the aortic stenosis can happen. Then chronic rheumatic fever. This is the reason for all the valvular disorders mostly. So these are the major reasons. Mechanical stress over time, bicuspid valves, that means the aorta is having only bicusp, then aortic valve is only having bicusp, then chronic rheumatic failure. So this is about the causes of aortic stenosis. Next, the pathophysiology. When aorta is not opening properly, left ventricle exert more pressure that eventually push the valve open. So what is there? Aortic stenosis is there. That means it is not opening properly. So anyway, the left ventricle want to eject out the blood. So what the ventricles will do, it will exert more pressure that will eventually push the valve open. So that will cause, due to continuous exertion of high pressure, the left ventricular muscle thickens. That is known as left ventricular hypertrophy. So less blood to the body. So as the stenosis is there, from the left ventricle only, the blood will be passed to the aorta and aorta to the body parts. So if there is insufficient blood supply to the aorta, what will be there? Obviously, there will be less blood to the body. So that is known as heart failure. The heart is unable to provide proper blood to the body. That can cause signs and symptoms like syncope. Syncope, when it is happening, if there is decreased blood supply to brain is there, then syncope can happen. Then angina, if myocardium is getting decreased blood supply, then chest pain or angina can happen. Then microangiopathic hemolytic anemia. What is this? Due to the blood is pushed through the valve. Okay, in aortic stenosis, blood is pushed through valve. So what is happening? Due to the pressure, the RBCs will crush. The RBCs crush, so that that will lead to hemolytic anemia, and it can even lead to hemoglobinuria. That means hemoglobin is going with urine also. Okay, so this is known as microangiopathic hemolytic anemia. So this is also there in aortic stenosis. Then clinical manifestation, signs are like ejection, systolic click will be there. Then carotid thrill, in the carotid arteries we can observe or we can palpate the thrill due to the turbulent blood flow. Then low systolic BP will be there. The systolic BP will be low. And soft S2 sound. The S2 sound will be soft. Why? Because with the closing of the aortic valve only the S2 is happening. So it is not opening, so that the closing also is problematic, and that will lead to soft S2 sound. It is closing anyway, but it will be soft. Then ejection systolic murmur in aortic area we can auscultate. Then Burnham phenomena. Then symptoms, angina, as I already said, angina. Then syncope, then dyspnea, and sudden death can also happen due to complete heart block. Okay, complete heart block can happen. That will lead to arrhythmias like ventricular fibrillation, and it will lead to sudden death. Next, we are moving on to aortic regurgitation or insufficiency. So here you can see regurgitation means inappropriate closing, and where blood will be backing to the left ventricle. Causes aortic root dilation. So if the aortic valves are here and the roots are dilated, so that means the roots are dilated means the distance between the valves will increase. Okay, so aortic root dilation cause the distance between the valves to increase. That will finally leads to aortic regurgitation. Then if aortic dissection or injury to the aorta can also cause this condition. Then aneurysms. Aneurysms is another disease condition. We will discuss it in detail. Bulging of the arteries that can finally cause rupture, and it can also lead to aortic regurgitation. Then syphilis. How can syphilis cause? And third stage of syphilis, it can even cause aortic regurgitation. Remember this, even syphilis, it is an infection, mainly a sexually transmitted disease. So this syphilis can also cause aortic regurgitation. So you can get a question like this one: sexually transmitted disease. Which sexually transmitted disease can cause valvular disorders like aortic regurgitation? That is syphilis. Syphilis in its third stage can even affect the aorta and cause aortic regurgitation. So whenever we are studying the syphilis, we will discuss it in detail. Then the valvular damage. Already the valve is damaged, or congenital disorder. Congenitally, the valve is having some problems. Or like parachute valves. So in those conditions, congenitally the valve is damaged. That can finally, as it progresses, it will lead to aortic regurgitation. Then the pathophysiology. The aortic valves are not competent, so that what will be there? Blood goes back to left ventricle. So that is regurgitation. No, blood will go back to left ventricle. So that increased blood volume in the LV or left ventricle, then increased left ventricular stroke volume and low diastolic aortic pressure. So what will be there? Increased left ventricular stroke volume. The left ventricle is ejecting so much blood because there is increased blood volume in the left ventricle. So it is ejecting out so much blood. Now, more than normal, the left ventricle is ejecting out the blood. That is, the stroke volume will be increased, but the blood is again regurgitating back. That will lead to low diastolic aortic pressure. That means there will be increased systolic BP and decreased diastolic BP. And that will finally leads to wide pulse pressure, because it is the pulse pressure is the difference between systolic BP and diastolic BP. So due to this phenomena, there will be wide pulse pressure, and that will lead to signs and symptoms. Okay. So the symptoms of aortic regurgitation is more or less same as aortic stenosis only, but the science in aortic regurgitation is very, very important. You can get questions only mainly from this part. You can get so many questions. So kindly listen, and if you want, note down also. So there are so many signs in that. So let's start the signs first from the head. So the first thing is lighthouse sign. Lighthouse sign, that means alternate flushing and blanching of forehead. So let's start from the head. So in aortic regurgitation, the patient may show lighthouse sign. That means alternate flushing, blood flushing, and then blanching. Blanching means without blood. So alternate flushing and blanching we can observe in the forehead. Then we are coming to the eyes. That is Landolfi sign, change in pupillary size according to the cardiac cycle, or with each heartbeat, the pupil size will increase and decrease. So that is Landolfi sign. Then third one is Bucker's sign. That means retinal artery pulsations. Even the retinal artery also the pulsations will be there. That is also in eyes only. Then head bobbing with each heartbeat. This is a repeated question also. D-Mussett sign. D-Mussett sign is head bobbing. Head is bobbing with each heartbeat. That means due to that much pressure for that beats, the head will be moving. That is D-Mussett sign. Then Muller's sign. Muller's sign means systolic pulsation of the uvula. Uvula is, so the head we saw what is the sign, that is lighthouse sign. Then in eyes, Landolfi sign and Becker's sign. Then the head bobbing is the D-Mussett sign. Then Muller's sign is in the mouth, that is in the uvula pulsation we can observe. So that is Muller's sign. Then Quincke's sign. Quincke's sign, we are coming to the limbs, that is in the hands. Nail bud capillary pulsation. Even the nail, if we are observing, we can see the capillary pulsation in the nail bud. That is Quincke's sign. Then locomotor braking. So that is pulsation seen in brachial artery. In brachial artery, we can see the pulsation. That is also in hand. Then collapsing or water hammer pulse. This is also a repeated question in so many question papers. Water hammer pulse can be seen in which disorder? That's or collapsing or water hammer pulse. So water hammer pulse can be seen in aortic regurgitation. Okay. So large stroke volume and diastolic emptying of aortic blood into ventricles. So due to this, there is water hammer pulse. Okay. So that much pressure to the arteries are there. So that is causing a collapsing type of pulse. But it is also known as water hammer pulse happening in aortic regurgitation. So I will also give you a mnemonic for this. Don't worry. So if you can remember like this, you can remember like this, or otherwise you can use the mnemonic also. I will give you anyway after explanation. So next is Thromb's sign. So next we are moving on to the femoral artery. So we are dealing with limbs, no? The hand is completed. Next we are moving on to the legs. So these three signs, 1, 2, 3. These three are about femoral artery or the femoral area. So Thromb's sign means pistol short femoral. So if you are palpating, we can see a pistol short like pulsation we can see in femoral. That is the Thromb's sign. Then Durossi's murmur. Two things are there, Diastolic murmur and Diastolic sign. These two are also seen in femoral area only. So, Diastolic murmur means diastolic murmur heard over femoral artery when it is pressed distally. Distally, if you are pressing with the diaphragm of the stethoscope, there will be diastolic murmur. You already know the difference between diastolic and systolic murmur. So a diastolic murmur can be heard if we are pressing the femoral artery distally with the diaphragm of the stethoscope. Then Diastolic murmur we can hear. In Diastolic sign, there will be systolic murmur heard over femoral artery when it is compressed proximally. Proximally, if you are pressing it, we can hear this systolic murmur. So how can we differentiate whether it is diastolic or murmur or systolic? I used to remember like if it is sign S is here, no? So this is also systolic, so S is here. So Diastolic sign means systolic murmur and Diastolic murmur is diastolic murmur. Okay, so these three are about the femoral. Then Rosenbach sign. Rosenbach sign means liver pulsation is there. Next one is Gerhardt sign. In this, spleen pulsation is there. Then Oliver Cadavalli sign. In this, larynx pulsation is there. Then Dennison sign. Even cervix also in females. Cervical pulsation also we can observe. That is Dennison sign. Then Hill sign. Hill sign means the popliteal cuff systolic pressure exceeds the brachial cuff pressure by more than 60 mm of Hg. Usually the BP will be measured here in this area, the brachial area. So if we are putting the cuff, therefore checking the BP in the legs also, in the popliteal area also, the BP will, the popliteal cuff systolic pressure. That means the systolic BP which we checked in the popliteal area will exceed the brachial cuff pressure. That is about 60 mm of Hg variation can be there. That is known as Hill sign. So this is about the signs. You can even remember like from head, what are the symptoms. Okay, so from head it will be starting like lighthouse. Then in the eyes, Landolfi sign and Becker sign is there. DMSH sign, head bobbing. Then Muller sign, we are coming to the mouth, that is the uvula pulsation. Then Kuhnke sign. Next we are moving on to our limbs. Then upper limbs. In hands, what will be there? Nail bud capillary pulsation, that is the Kuhnke sign. Then locomotor brachii, the brachial artery pulsation. Then water hammer pulse is also seen in aortic regurgitation. Then we are moving on to the legs. In legs, in femoral, Trop sign. Diastolic murmur is in diastolic murmur. Diastolic sign is in systolic murmur. The murmur can be heard. In liver, Rosenbach sign. In spleen, Gerhardt sign. In Oliver Cadavalli sign is about the pulsation of larynx. Cervical pulsation is Dennison sign. And if the popliteal cuff systolic pressure exceeds brachial cuff pressure by more than 60 mm of Hg, it is known as Hill sign. It is so much signs, no? So it may be difficult for you to remember also. So you can remember this mnemonic. Okay, German bakery near the lighthouse is in trouble as the demand for land in hill station rose quickly. So some people can able to remember better with the help of mnemonics. Okay, some people will remember it like head to like the way I explained. Some people used to remember in that way. Some people need mnemonic for better remembrance. So this is for those type of people. German bakery near the lighthouse is in trouble as the demand for land in hill station rose quickly. So you can take the first words as the bold words. German means what is the thing? Gerhardt sign. That is Gerhardt sign is, what is Gerhardt sign? Spleen pulsation. Becker's sign, B for Becker's, retinal artery pulsations, then lighthouse sign in forehead, flushing and blanching, then trouble T is trop sign, pistol short femoral, then D message sign, head bobbing, and L for Landolfi's sign, that is pupillary increase and decrease in size of the pupils. Then H for Hill sign. In Hill sign, the popliteal cuff pressure exceeds the brachial cuff pressure for about 60 mm of Hg. Then for R is the Rosenbach sign, that is the pulsation of the liver. Then Q, Kuhnke's sign, that is, what is Kuhnke's sign? Nail bed capillary. The nail bed, you can see the capillary pulsations. So this is about this much signs. Then another mnemonic, that is Dennis murmured multiple times to Oliver, his durable friend. So from here also you can take the first words. Dennis means Dennison sign, that is pulsation of the cervix. Here you can see Dennison sign, cervical pulsations. Then murmur, that is the Durosis murmur is given like, Durosis murmur is given like this word, Durosis murmur, that is the diastolic murmur heard in the femoral area. Then multiple time to Oliver. So this M is Muller's sign. Muller's sign is pulsation of the uvula. Okay. Then Oliver. O is Oliver Cardavelli's sign, that is the pulsation of the larynx, his durable friend. This is Durosis sign. D for Durosis sign, that is the systolic murmur. Okay, so you can also remember in this way also. Okay, so mainly try to remember this head bobbing sign, then the water hammer pulse, and from this, those two are repeated question. Even question can come from any of the signs also. So better remember these signs so that it will be easy for you people in theory exams. So next we are moving on to the surgical management. Okay, the main surgical management, commissurotomy procedure performed to separate fused leaflets. The leaflets are fused together. So for that, commissurotomy can be done. Valvuloplasty or percutaneous mitral catheter balloon valvuloplasty. So this is another surgical management. As the coronary angioplasty, using the balloon, the area will be inflated. Then balloon catheter inflated with a dilute angiographic solution. So using the angiographic solution, a balloon catheter will be inflated in that area. Then annuloplasty. Annula, we already discussed in the anatomical, but what is an annula? That is the rings. Rings for supporting the valves are known as annula. So this, if the rings are not well, then it cannot provide support to the valve. So for that, annuloplasty will be done. So this is for the surgical management, not only for aortic regurgitation. These surgical management is for all the valvular disorders. Commissurotomy, according to the problem, we will do the surgical management. So these are all conservative surgeries like commissurotomy, valvuloplasty. So the present valve, we will do repair for that valve. This balloon catheter inflated with a dilute angiographic solution also, we are not replacing. With the same valve, we will be doing some repair. In annuloplasty, the annulum will be repaired. And if no other ways are there, the medical management and these conservative surgical managements are failed, then we will go for what? We will go for valve replacement. So this is a very big surgery. So in this, the valve replacement, the valves are of two types. Here you can see mechanical valves and bioprosthetic valves. Okay. So in mechanical valves, if the patient is having mechanical valves, we will, while auscultating, we will get a characteristic click sound. Okay, characteristic click sound we can observe in case of mechanical valves. Even mechanical valves are divided into bi-leaflet. In the picture, you can see how it will be. Then monoleaflet, only one leaflet is there. Then caged board, it's like the shape is like a caged board. That is about mechanical. In bioprosthetic, it can be stentless, even with stent, without stent, and transcutaneous also. So these are the two types of valves. So according to the financial ability and according to the need of the patient, we will be providing the type of valves. So the bioprosthetic valves are more costly. Then after this valvular replacement, we can expect some complications. So we will see the complications and how to tackle it. First one is the thromboembolism. So this is a foreign body which is placed in our body. So obviously what can happen? Thrombosis can happen into the prosthesis. To the prosthetic valve, thromboembolism can happen. For that valve, we will give anticoagulant therapy. Start 48 hours after surgery. Immediately, that means after 48 hours of surgery, we will start anticoagulant therapy for preventing this thromboembolism. So, which anticoagulant is more preferred is like warfarin. We will be giving for this patient, warfarin therapy. So, if the patient is on warfarin therapy, or if the patient is having a mechanical aortic valve, obviously the patient is on anticoagulant therapy, so that the INR or international normalized ratio of this patient can be normally it can be 2 to 3 is the normal value for mechanical aortic valve. So mechanical mitral valve replacement 2.5 to 3.5. So this is for the patients in warfarin therapy, we will consider the INR value or we will maintain the INR between 2.5 to 3.5. So in normal persons, what will be the INR value? INR value, why we have to see? Normally, PT and INR, we will be checking in a person to identify bleeding tendencies in a patient. Okay. So those who are with this valve replacement or those who are in this warfarin therapy, obviously bleeding tendencies will be high only. So anyway, we cannot stop the warfarin therapy, because if you are stopping warfarin therapy, that can cause thromboembolism. So we will maintain the INR value between 2.5 to 3.5. It should not go above 3.5. So between these values, we will keep the INR. So those who are with the warfarin therapy, they should continuously check their INR level. Frequently, they have to check their INR level, and it should be maintained between 2.5 to 3.5. So warfarin therapy, mostly 2.5 mg is the initial dose. Mostly 2.5 mg is the dosage of warfarin, which will be given for the patient after valvular replacement. Next is prosthetic valvular thrombosis. We already discussed this. The prosthetic valve undergo thrombosis. Then prosthetic valve endocarditis. So even the prosthetic valve, the valve which we placed, undergone the endocarditis. So again, the valve is failed. Then prosthesis malfunction or valve failure. We place the mechanical or the bioprosthetic valve there and the valve is not functioning properly. That means the valve failure. That is also a complication. Then valve degeneration. The valve which we placed degenerated. So anyway, it is a foreign body, so that degeneration can happen. Then paravalvular leaks. From the valve is not competent enough, so that leaks are happening. Then hemolytic anemia due to shortened RBC survival time in all patients. So hemolytic anemia is also a complication. So this is about the complication of valve replacement. Then warfarin therapy. So I already said in warfarin therapy, the usual dose will be 2.5. Then during warfarin therapy, the INR we will maintain between 2.5 to 3.5. In normal persons, the normal INR is, we should maintain it less than 1. Okay, in normal persons, it should be less than 1. But in warfarin therapy, the INR we will maintain between 2.5 to 3.5. Okay, so 2.5 is the dose. Okay, these are the basic things about warfarin. So while taking warfarin, there are some do's and don'ts. Do's is carry the booklet. That means after the surgery, the patient will be provided with a booklet about this do's and don'ts. Then inform bleeding. So in warfarin, while the patient is on warfarin therapy, they are having increased chance for bleeding. So if any type of bleeding is happening, they should be informed the health professional. Then remind about anticoagulants. The thing about warfarin therapy is do not miss a dose. A single dose also should not be missed. Every day throughout the life, they have to take this. Then same time, try to take the medicine, same time every day. Don'ts means should not miss the dose, should not take an extra dose that can cause increased bleeding tendencies. Then run out of tablet. That means the patient should not say that I didn't take the tablet because I'm not having. You should have it in excess. Okay. Then should not take aspirin with warfarin. Then on crash diet or binge eating should not be done. Alcohol should be avoided whenever the patient is on warfarin therapy. Okay. So in this warfarin can have if a pregnant woman is taking this warfarin, it can cause teratogenic effects in the baby or in the fetus. That means increased bleeding tendencies in the fetus or bleeding in the fetus can happen. So, so the warfarin is a drug which can cause teratogenic effects in the fetus. But according to our priority, what is our priority? According to that, the mother will be saved. Mother also should be saved. So according to the priority, the therapy will be started according to the doctor's decision. So here you can see some diet which we can take with the warfarin therapy after valve replacement. Okay, so whenever you are taking warfarin, the thing you should note is the vitamin K rich food you should avoid. Avoid vitamin K rich food. Why? Because it is the antidote. Vitamin K is the antidote of warfarin. Vitamin K is the antidote for warfarin. So if we are taking warfarin and we are taking vitamin K rich food, what will be there? The result will be negligible. Nothing will be there. Neutralized. The effect will be neutralized. So while on warfarin therapy, we should avoid or less the vitamin K rich food. So what are this vitamin K rich food? So this is given here. The high vitamin K content is in green leafy vegetables like spinach. Even the amount is also given here. You can even refer afterwards. And in beetroot also the vitamin K rich food. Then green turnip, coriander leaves, vitamin K is present. And meat liver, vitamin K is there. Spring onion, cabbage, lady's finger, peas and all very less. Cauliflower also very less. So this spinach and all the patient should avoid. The other things like a very small amount only vitamin K is present, very limited, weekly once or very limited amount the patient can take. Okay, so the amount for spinach and all 890 mcg of vitamin K is present. Okay, so the amount is also given here. You can even refer afterwards. So these all are the food the patient in warfarin therapy should avoid, because these foods are rich in vitamin K, which is the antidote of warfarin. Next, when we should means the patient on warfarin therapy report to a healthcare professional. That is bleeding from nose. What is bleeding from nose called? Epistaxis. If epistaxis occur, then he or she should inform to the doctor. Any bleeding, like bleeding while brushing teeth, joint swelling or pain, this can be hemarthrosis. That means accumulation of blood in the joints. Okay, so joint swelling or pain is there, then we have to report. That means the patient on warfarin therapy should report. Then excess menstrual bleeding or blood in urine. So any type of bleeding is there, then the patient should report to the healthcare professional. Then report to your doctor if you have cough, chest pain, palpitation, nausea, vomiting, anything is there, means the patient on warfarin therapy should inform to the doctor. Okay, giddiness, anything is there. Then if you have jaundice, leg swelling, missed periods, then body aches, abdominal distension, any of these symptoms are present, means the patient in warfarin therapy should inform to the doctor, because these can indicate abnormalities or complications. Okay, so that's all about the class. So we discussed about valvular disorders. So any valves can undergo stenosis or regurgitation. Stenosis and regurgitation are the main conditions, main valvular disorders. So in stenosis is what? Stenosis is a opening problem, and regurgitation is a closing problem of the valve. Okay, so that is the stenosis and regurgitation are the main two problems, and in all the valves can be affected with this stenosis and regurgitation. But mainly or more layer of the heart are the valves made of? What layer of the heart are the valves made of? A, epicardium, B, pericardium, C, myocardium, and D, endocardium. So someone answer, let's see. C is myocardium. So the valves are made of endocardium. Okay, the valves and chambers of the heart are lined or made with endocardium. Okay, the valves and chambers of the heart are covered or lined with endocardium. So that's why you can even connect it with the disease condition, i.e. infective endocarditis, which is the major problem in major disease condition causing valvular disorders. Endocarditis, infective endocarditis, that will cause inflammation or problem in the valves. So endocardium is the layer covering the valves as well as chambers of the heart. Okay, so this is the first question. Moving on to the second one. Bobbing of head is seen in. This bobbing of head is seen in aortic stenosis, aortic regurgitation, mitral stenosis, and mitral regurgitation. Can anyone answer? Bobbing of head is seen in aortic stenosis, aortic regurgitation, mitral stenosis. Yes, your answer is right. Iotic regurgitation. Okay. So what is this bobbing of head is called? What is the name of the sign? Bobbing of head in aortic regurgitation? Demusset sign. Okay. Demusset sign is known as bobbing of head in aortic regurgitation. Okay. Next, third question, the last question. Which valve disease cause increased chance of death during labor or childbirth? Which valvular disorder can cause increased chance of death? A. Mitral stenosis. B. Mitral regurgitation. C. Aortic stenosis. D. Aortic regurgitation. Can anyone say? What?
Mitral stenosis.
Yes, you are right. Mitral stenosis is the condition which is causing increased chance of death during labor. Even with other valvular disorders also, the mortality can happen. But with mitral stenosis, as per the statistics, the mitral stenosis is the main valvular disease which is causing increased chance of death during childbirth or labor. Okay, thank you, Srimati. So this is about the class. So in this way, the questions can be given. Okay, so like this is just an example of question. So in this way, deep from the theory, the questions can be given. So anyway, again, go through the contents. Anyway, I think this is little confusing also, the stenosis and the regurgitation of each valves, and especially you should see the signs of the aortic regurgitation. Okay, so whatever way it is comfortable, try to remember it. Okay, so thank you everyone. That's all about the class. We will see in the next class. Bye. Thank you.